My name is Maisha Saeed, and today I want to discuss the benefits and drawbacks associated with introducing traditional birth attendant TBA training and maternal empowerment strategies in South Sudan, which has one of the worst maternal and newborn outcomes in the world. South Sudan has a lack of health professionals, with the bulk of the health workforce being community health workers, most of whom can only deal with basic healthcare. TBAs play a crucial role in the care of mothers in South Sudan, with approximately 90% of women still giving birth at home. One evidence-based training program for TBAs has already been implemented in South Sudan, which has been found to be effective so far in improving TBA skills. Similarly, maternal education and empowerment has been shown to reduce the number of unsafe home deliveries by a study in Darfur, Sudan. Despite the promising outcomes of both of these studies, some common underlying factors create large setbacks. Firstly, lack of access of healthcare facilities due to geographical boundaries and lack of emergency transport. Training TBAs to deal with more specialist issues could help to reduce the strain of seeing other health professionals in clinical settings, but in the case of emergencies and issues beyond the scope of general training, transporting women or referring them to a health facility is often not possible. The Maternal Education Initiative in Darfur, as I mentioned earlier, had camps set up with clinics, health professionals, and door-to-door maternal education and ambulance services in the study area. Given the resources available, the positive outcomes and increased usage of clinical facilities was not surprising. In reality, however, very few areas have such facilities readily available in South Sudan. Furthermore, empowerment strategies used in one setting cannot necessarily be implemented in another, without respecting cultural differences. Moreover, integration of any initiatives into the health system will likely require policy and governance changes, which would require the cooperation of the government and the buy-in of external donors and providers such as any NGOs in South Sudan. Clearly, community action can be effective, but not alone. Both governmental and non-governmental organizations need to work together to ensure the introduction of these programs alongside relevant resources by introducing relevant policy changes, altering health system structure, and addressing root issues in communities such as gender norms. A preliminary way of tackling this could be the introduction of more women's discussions groups and the normalization of such groups, so that women have a safe place to speak up and have their voices heard. Another could involve making the study of gender equality compulsory as part of the schooling curriculum across the country, so that children grow up breaking the gender stereotypes of the generations before them. This has to be done in tandem with the implementation of community-based strategies to see the most immediate effects. I hope my proposal is of interest to you. Thank you for listening, and I am happy to take any questions via the app or the website throughout the day.
The power dynamics and relationships in global health have interested me ever since I sat in a lecture on helminthic infections and saw a picture of an all-white, majority-male group of experts in Geneva illustrating a new policy announcement for treatment of under 5s in sub-Saharan Africa. Who were these men, and how did they get to make the decisions? Decolonising global health means more, though, than where decisions are made or meetings are held. Colonial legacies still shape global health internationally and within institutions. Funding, governance, teaching and partnerships can all display colonial power imbalances. Implicit bias regarding Western education superiority, economic disparities between expat researchers and local staff, inadequate understanding of local contexts and cultures, research partnerships which fail to disseminate and implement research findings in the country the data came from.
Health solutions are being imposed onto low and medium income countries by experts that don't have full knowledge of the local environment, the cultures, and no full respect for local leadership. And to me, it seems global health is not a one-size-fits-all, and local researchers ought to be given priority in global health forum, and their publications should be the ones taking lead in the shaping or the construction of health guidelines and policies, because Western solutions are not always relevant or even effective for that matter.
So what about then some solutions? For me, the answer included working in a government hospital in Zimbabwe as part of a local team where we all learn and share experiences without the hidden agenda of a predetermined research project to implement or data to collect. Other short-term suggestions I've seen: mandatory courses about the colonial history of global health, training in cross-cultural working and cultural humility, strengthening expertise and building capacity within low-income countries. Ultimately, though, we need to challenge the assumptions, values and power imbalances within global health. We must examine the working practices of all institutions, governmental and non-governmental organisations. Students, researchers and practitioners in the Global South require an equal voice and opportunity.
I want to be part of the solution and part of the process of decolonizing global health by studying global health itself and also its determinants and getting involved in local research so that I strengthen local research as well as boost the confidence of researchers that are already existing.
Global health is about equity and justice. We must all reflect on our motivations and methods, encourage new perspectives even if they're uncomfortable, and make sure we challenge rather than reinforce colonial patterns wherever we live and work.
We have successfully brought in many more women to deliver in health facilities across many low and middle income countries, but sadly not match that with service quality. How do you change entrenched practices in large organizations and complex health systems? Lucy Gilson, almost 20 years back, astutely reminded us, and I quote, that health systems are inherently relational, and so many of the most critical challenges for health systems are relationship and behavioral problems. Changing behaviors in large, complex health systems is not easy, which might explain some of the dismal performance we see of many interventions aimed at this. We were interested in exploring one intervention being implemented in India to improve the quality of care provided by labor room nurses in public primary healthcare facilities, that of peer-to-peer nurse mentoring of nurses, labor room nurses in the health facilities where they posted. In the states of Uttar Pradesh and Bihar, this intervention was implemented across 600 public primary health facilities and has shown improvements in several practices critical to saving newborn and maternal lives. We were interested in understanding why this intervention was relatively successful when so many others have failed. How did the nurse mentors, who initially encountered resistance, manage to successfully facilitate change? Are there lessons for other settings on what works to bring about organizational and behavioral change in large hierarchical and bureaucratic public services? We used qualitative methods, interviewing nurse mentors, nurses, other health facility staff, and program leadership across both settings. We found mentors created a safe place for learning and the desire to change practices by taking the time to build rapport and to earn the mentees' trust. They did this through respectful interactions, treating nurses with dignity, while modeling desired behaviors and practices. This was a departure from the hierarchical, punitive ways of relating and interacting, and helped create a secure and receptive environment for change to unfreeze some of the entrenched ways of being and relating to facilitate improvements. The ongoing presence, 8 months or longer, of the nurse mentors was critical in building confidence for nurses to practice new skills and in habituating those practices. And it probably needs to be longer for sustainability. Nurse mentors were supported in both hard and soft skills by program managers by deliberate and ongoing actions to not only create an enabling environment, but also allowing mentors the freedom to tailor the program according to local needs and context. This support also subtly communicated institutional backing to all key stakeholders. And lastly, targeting a discrete part of the public health service, such as the labor rooms, to help demonstrate the ability to make change without overtly challenging the status quo, and broader health system, which could reject rather than embrace the change, and demonstrated that this can meaningfully set the stage for incremental change to happen system-wide. To conclude, we need to intentionally acknowledge that health systems are relational and that these relations are embedded in larger socio-cultural and political systems. Therefore, solutions to some of the most persistent healthcare challenges require time, resources, and a deep and ongoing understanding of the organization and its context.
Hello, I'm Susan Bradley and I'm from City University of London. I'm going to talk to you today about why workplace bullying needs to be considered if we want to address respectful maternity care. The phenomenon of workplace bullying has been well documented in nursing and midwifery services in high-income countries, but has been underexplored in low-income contexts. The literature describes workplace bullying as a common, persistent, pervasive problem which manifests in behaviours such as hostility, harassment, negative criticism, undermining behaviours, unwillingness to help out, and lack of support. While individual acts may seem insignificant, they can have a cumulative negative impact. At the individual level, they affect physical and psychological well-being, reducing job satisfaction, motivation, and professional confidence, and damaging self-esteem. Organisationally, workplace bullying causes attrition and staff absenteeism, and it negatively affects the teamwork and interprofessional collaboration that are so crucial in maternity care. Together, these have a significant impact on quality of care, including respectful maternity care, and I think this is likely to be more acute in high burden services such as maternity. In 2016, I spent 6 months in Malawi interviewing midwives in a range of national and district level key informants to explore midwives' perceptions of the impact, practice, and challenges of delivering respectful care. An emergent finding, which has not been widely addressed yet, was a link between workplace bullying, locally known as pull-down syndrome, and disrespect of colleagues and labouring women. I'm just going to give you a few examples of workplace bullying from my research findings, which I think exemplify the themes that arose, and ask you to think about how these might impact midwives' ability to provide respectful and quality care. In one hospital, a midwife knew that back massage was an effective pain management intervention in the context of a labour ward with no analgesia, and saw it also as part of evidence-based respectful care, but he felt he couldn't provide it when certain colleagues were on duty because they would ridicule him and make humiliating comments. In another facility, hard workers were routinely targeted and left to do all the work, while their colleagues sat back and left women calling for help, and this inhibited other staff from trying to improve their own performance. Many participants also described the lack of support from senior management and the risk of bullying and retaliation if managers tried to hold staff to account. For example, a very nervous human resource officer told me off the record that they had received death threats for following the organisation's disciplinary protocols. So workplace bullying undermines midwives' efforts, it compromises respectful care, and a significant number of participants felt these behaviours were tacitly accepted and normalised in the Malawian health system. To explore this further, our team are deepening the understanding of workplace bullying in maternity services and trying to find solutions to address it. We're working in Malawi, Sudan, and India to explore how workplace bullying manifests in maternity services in each of these contexts and to gather stakeholder input on mechanisms and policies that can be developed to address it. Our aim is to provide policymakers and planners with relevant, transferable evidence which can inform human resource practices that reduce bullying, support performance, and enable staff to provide equitable quality care, including respectful maternity care.
Hi, my name is Jiva John, and I am an obstetrics and gynecology registrar in Edinburgh. My co-author is Dr. Gwinnetta Curry, who's a lecturer at the University of Edinburgh. Our combined interests led us to the topic of the history of gynecological care for Black mothers and its potential impact on hospital admissions from COVID-19. During the period of slavery in the US, a large amount of medical experiments were conducted on Black slaves. J. Marion Sims continues to be widely regarded as a pioneer of modern gynecology, but was a perpetrator of unethical surgical experiments on Black female slaves. The current literature on patient-physician relationships have found that physicians still see Black women as able to endure more pain than their white female counterparts, which means that Black women are less likely to be prescribed analgesia. The persistent view of Black women's bodies as being more durable than white has continued into modern medicine. Globally, women continue to suffer intersecting forms of discrimination and disadvantage, including but not limited to gender, race, and socioeconomic status. Consequently, and unsurprisingly, maternity care can be challenged by prejudice and structural inequalities within and beyond the realms of the healthcare system. The COVID-19 pandemic has further highlighted these ubiquitous discrepancies. Widespread racial and structural inequalities in these areas will negatively impact the core determinants of health, thereby undermining a woman's chances of achieving healthcare equity even before they encounter the healthcare services in pregnancy. The gulf in maternity outcomes between white women and women from ethnic minority backgrounds, especially Black, has continued to expand. The Embrace UK 2019 report showed that Black women in the UK were 5 times more likely to die than white women in pregnancy. Black women's maternal mortality rate has remained disproportionately higher than white women for over a decade, and this unacceptable healthcare outcome variation is reproducible in many countries of the global north. Racial disparity in the UK hospital admissions due to severe COVID-19 has extended to the pregnant population, with Black ethnicity being regarded as an independent risk factor for hospital admissions due to COVID-19, and reinforces previous findings that Black pregnant women have worse maternity outcomes. This suggests that pregnant Black women currently are even more vulnerable to maternal morbidity and mortality compared to the increased risk that is well established. Given the healthcare outcome disparities between Black and white patients that are now under spotlight in the 21st century, and the atrocities that were being committed on Black slaves in the not too distant past, it is important to investigate empirically what role racism plays in the ongoing race-based health outcome discrepancy in the present day.
Hello, we are the organizing committee of the Virtual International Day of the Midwife, or VIDM.
The VIDM is a free, non-profit 24-hour online conference held every year on the International Day of the Midwife, the 5th of May.
In 2020, the conference included 38 presentations and 24 posters in English and Spanish, covering a wide range of birth-related topics.
The VIDM also hosted 2 pre-conference sessions from the World Health Organization, providing COVID-19 pandemic updates.
Participants came from at least 32 countries as diverse as Afghanistan, Bolivia, Iran, and Nigeria.
2020 saw our highest attendance figures since the initial 2009 conference, which was broadcast from our founder's kitchen in New Zealand.
A volunteer committee of senior educators, technologists, midwives and student midwives from 9 countries organises this conference.
We are passionate about celebrating and sharing midwifery knowledge, research and clinical practice globally to reduce disparities in educational opportunities.
Midwives care for increasingly diverse populations within their own countries and internationally.
This has led to a growing need for midwives to receive education in the field of global health, as well as collaborate with other midwives globally. International conferences, however, come at a high environmental price.
The VIDM offers innovative opportunities for collaboration between midwives, student midwives, researchers, and educators within a socially responsible international context.
Without the need to travel, participants minimize their carbon footprints.
Rather than providing a passive education of videos and online e-learning, the VIDM is an interactive conference. We use web conference software, allowing delegates to text chat with each other through sessions, participate in online polls, and ask real-time questions directly to speakers.
It can be challenging to coordinate a 24-hour conference covering all world time zones, peer-reviewing multilingual abstracts, recording podcasts, and supporting presenters to be confident in the virtual world.
We were commended for our work in the International Education category at the International Maternity Expo Awards in November 2019.
The VIDM is committed to global midwifery education and continues to provide a free, equitable and accessible conference on International Day of the Midwife.
Check out our video YouTube channel, Virtual Midwives, to look at our free resources. You can access the VIDM's website to find out how to submit an abstract or poster, as well as instructions on how to access the conference.
We look forward to seeing you at the VIDM 2021.
Whoever described a coin by only looking at one of its sides? Ablawa is a 38-year-old woman. She has been treated for severe preeclampsia at a moment where the hospital was experiencing a power outage. She suffered from unreasonable requests, as walking from the hospitalization room to the delivery room while she had already the head of the baby at the vulva. Delivery experience resulted in a stillbirth. This kind of experience is described from this unidirectional perspective in the mainstream research on disrespect and abuse. This unidirectional perspective misses second side of the coin of this phenomenon. Indeed, in the Ablawa's experience, we observed that she did react. For instance, she tried to make comments and seek for attention. Her family also reacted. For instance, during the power outage, They went to borrow a torch to bring light to support in the delivery experience. This whole set of responses to the practices of providers correspond to an important side of the D&A phenomenon. Building on more than 20 years of research, we have come to the conclusion that we need a new framework to study the issue of disrespect and abuse. We started from the concept of disrespect and abuse events. That is a set of practice, response, and all the dimensions of those two elements. The practices can have up to 8 different dimensions. We have a perpetrator, we have a victim, we have a timing of this in the continuum of care. We have a place, a harmfulness, and have also an intentionality. The response from the women's side have also the content, the respondent, the target of the response, the timing, the place, but also the main purpose of this response. The outcome results from a dynamic interplay between those two components, the practice and the response. Embracing this bidirectional perspective enlarge our options to intervene. For instance, instead of only training providers, we can also empower women and their families and have more context-sensitive reactions that can help them to address from within the context this very complex phenomenon.